Good morning and welcome to the first ever Virtual Cancer Policy Roundtable. I'm Elena Janot, Vice President of External Relations here at NCCS, and I have the pleasure of welcoming you here today. As you may know, this event is entering its 20th year and is typically presented in person. Today, we are bringing the same program to you virtually. We plan on a packed meeting with important conversations, and I'm glad that you've joined us today. At NCCS, we dedicate a lot of our meetings to people going through a cancer journey. Today, we'd like to dedicate this meeting to all of the healthcare workers who are putting their lives on the line for all of us during this COVID-19 pandemic. We are indebted to you. Before we get started, I'd also like to take a minute to thank our supporters and sponsors who are sticking by us through this really unprecedented time in our country. We could not do this without you, so thank you for all that you do. I'd also like to thank our speakers and panelists who are pivoting to go from a in-person meeting to this virtual meeting, and also to the NCCS staff who has done an incredible job and worked very long hours to bring this programming to you. At NCCS, we often say we like to see the bright spots through the gloom. And one of the bright spots today is that we are joined by hundreds of cancer survivors and our own CPAP members from across the country who typically are not able to join us at this meeting. I'd like to welcome each and every one of you here today. We are thrilled to have you. This meeting is all about discussing how to make your care better and your lives better. It's our passion and our mission here at NCCS. So thank you for joining us. So I just want to say one last thanks for everyone. We're thrilled to have you here. We're excited to see how our CPR transitions into a virtual meeting. I think it'll be a great day. We're going to be kicked off by Dr. Otis Brawley, who is a globally recognized expert in cancer prevention and control, and is currently a Bloomberg Distinguished Professor at Johns Hopkins University and a great friend to NCCS. So now I'd like to turn it over to Dr. Brawley.
Good morning, and thank you for having me. It's a pleasure to talk to you. I'd hope to be with you in person, but this actually is going to be an exciting trial for all of us. What I'm going to talk to you about is cancer control in this century as cancer has changed, with attention to disparities in health, as the definition of health disparities and the interest in health disparities is changing over time. My disclosures: I work for Johns Hopkins University, and I do some consulting for the federal government. I also published a book a few years ago. This talk has nothing to do with the book, but I still disclose it. Next, please. The leading causes of death in the United States are listed on this slide. As you can see, cancer is currently number 2. Behind heart disease. However, over the next 5 years or so, with the dramatic declines in heart disease death rates, actually faster than the declines in cancer death rates, you will see cancer become the number one killer in the United States. Already for certain populations, women, for example, over the age of 70, Hispanic women in the United States, cancer is the leading killer. Next. Again, cardiovascular death rates have been declining faster than cancer death rates. Next. This is a slide, and I'm an epidemiologist and medical oncologist, so pardon me for having a talk that's heavy in numbers and slides. This shows you the age-adjusted cancer death rate over the last 125 years or so. The way to read this is in 1900, for every 100,000 Americans, there were 64 deaths from cancer. In 1991, it peaked at 215, and in 2017, it was back down to 152. The much talked about 29% decline in the cancer death rate represents going from 215 per 100,000 Americans in 1991 to 152 per 100,000 Americans in 2017. Next, please. This is a slide that breaks up by race. These are the racial ethnic categories that are defined by the Office of Management and Budget in the White House as of 2010. Interestingly, the White House and OMB defines what race is. And you can see blacks have had the highest death rate, but it's going down faster than any other group. You can also see the death rate for whites, and there's a disparity between Native Americans, Hispanics, and Asian Pacific Islanders and whites. Next, please. Here you can see the same death rates for three of the four most common cancers: breast, prostate, colorectal. For colorectal, we've broken it down for men and women. And in breast and colorectal, you can see a common theme. In the 1970s, the black-white death rates were the same. In around 1980, the black death rate started going up. And then they started all going down in the early 1980s. And you can see in breast cancer for blacks and whites, the disparity in death is greater today than it has ever been. And keep in mind, there was no disparity prior to 1980 in breast cancer. And there was no disparity in the 1970s for colorectal cancer. And the noise, by the way, for Native Americans, the gray line is because they represent about 1 to 1.5% of all cancer deaths. The numbers are very small, and so we have the wiggly line is called noise. Next, please. Again, OMB defines race and ethnicity. Next, please. Keep in mind that race and ethnicity is a socio-political definition. It is not biological. It's been rejected by the anthropological community, and it changes over time. Next, please. There's been a lot of, when I say, by the way, it changes over time, there are certain people, people from India, for example, who've been considered Caucasian at one time, Asian at another. My favorite, by OMB White House definitions, President Obama was considered white in 1970 and black in 1980. There's been a lot of discussion about diversity in clinical trials by race. I just want to point out, in the future, we're going to realize that this is more of a political discussion and not a scientific discussion. It is really non-scientific. Now, we do need to encourage participation of all peoples in clinical trials, and there are differences amongst populations. It's just that race is not the appropriate way to categorize those populations. Next, please. Again, Ancestry.com has actually helped to tell us that race is not a very good categorization at all. A friend of mine once said it's kind of like slicing soup. Next, please. Ways that we can categorize populations. Won't go into this in exquisite detail, but these are three different examples of genetic variations amongst populations, and the populations are not defined by race. They're defined by area of geographic origin, and sometimes those areas of geographic origin can be very small, like just along the Thai-Burmese border, or my favorite is it's frequently not recognized that there are whites from Southern Europe with the sickle cell mutation and blacks from Southern Africa who never get it. Next, please. Again, there's a huge discussion about diversity in clinical trials, and clinical trials inclusion should be encouraged. Next, please. This is actually very important, as in the 21st century, we're going to be developing a number of precision drugs where we won't be able to get 300-400 people for phase 3 clinical trials. We're going to be focused much more on phase 2 trials that have 30 to 50 individuals in them, and we're going to be focused on people with common genomic or genetic targets, not using race, but looking at genetic or genomic targets like estrogen receptor positivity, is a great example of HER2 positivity, EGFR mutations, and that sort of thing. Next, please. Next, yeah. Now, let's talk about the decline in cancer death rates and why the decline in cancer death rates. The 29% is due to what I'll call wise early detection, especially early detection in colorectal, breast, and cervical cancer. I say wise early detection because there is unwise screening out there in which people actually get hurt. And then there's good prevention, especially tobacco control, as well as improvements in cancer treatment. Next, please. For example, breast cancer, we know that about 40 to 50% of the decline is due to screening and early detection, and 50 to 60% of the decline is due to improvements in our ability to treat breast cancer. I already noted that cancer screening, some of it can be wise. The thing is, cancer screening can be both beneficial, it can be harmful, it is often both, and we need to have good randomized clinical trials to assess it, and we need to follow the good science. I have some examples of that as we talk about lung cancer in a second. Next. This is Graham Coldit's publication looking at cancer prevention. I've actually come, because of some NCCS influences, to think that we should refer to this as risk factor reduction. A third of cancers are currently due to smoking. You'll note that you can add 20 plus 5 plus 5. 30% of cancers are due to energy balance, the combination of overweight, bad diet, and lack of exercise. Hereditary factors about 16%. On this list, please note 5% of cancers in the United States are due to viruses, primarily human papillomavirus, HIV, hepatitis B, and hepatitis C. If one were to go to Africa, viruses and infectious disease actually cause 25% of all cancers. Also, I want you to note on this slide alcohol at 3% and UV and ionizing radiation at 2%. Much of that is actually either sun exposure for about half, but also hospital-acquired radiation. CT scanner, for example, is a cause of cancer. Next, please. This is smoking in the United States. In 1955, 55% of all adult men smoked. In 1965, 35% of adult women, and it has declined over the years. Go to the next slide, please. Lost the slides. Yeah, that's fine. Tobacco is still a leading cause of cancer death in the United States. Next, please. This is the tobacco use rates among adults in 2017. You can see about 16% of men, about 12% of women. You can see the age distribution. The next slide will have the distribution by race and ethnicity. Note 24% of female Native Americans do smoke. That is not a misprint. This can be highly variable. If one goes to the Navajo reservations in Arizona and New Mexico, there is very little smoking. If one goes to the Plains reservations, there are very high levels of smoking. Next, please. This is by education. I still don't know why 37% of Americans with a GED are smokers. You'll note that education tends to lower one's risk of being a smoker. Next, please. This is smoking in 2013 by state. The darker states are the states that have the highest prevalence of smoking. We're talking about 27% of the residents of West Virginia and Kentucky smoking cigarettes, 10% or so of people in Utah and California smoke cigarettes. Next. Cancers caused by infection include HCV or hepatitis C, hepatitis B, HPV. These are all going up over time. You'll note that we have vaccines against hepatitis B and human papillomavirus and can control them through prevention. We also have very effective treatments for hepatitis C. We can literally cure 80 to 90% of people who have hepatitis C. Unfortunately, the treatment costs $40,000 to $50,000. Many of the people who have hepatitis C are poor and can't afford it. And we have some states that, as a policy, will not pay for the cure of hepatitis C through Medicaid dollars because it costs $40,000 to $50,000. Next, please. Energy balance is how I prefer to look at the problem of overweight, obesity, too many calories, and lack of exercise. Think of it as a three-legged stool. It is not just obesity. It is the combination of too many calories, not burning off of those calories through exercise, and then storing those calories through obesity. 2/3 of all adults and 1/3 of all children are currently overweight, and weight-related cancers are expected to increase over the next decade or so. You can think of that line of the 29% decline in cancer. That is smoking cessation and treatment pushing that decline downward, while the tendency of Americans in the United States to gain weight is pushing it upward. We have some slides later on to show you that trend. Let me show, and important to this slide, with the decline in tobacco use, energy balance will become the leading part in the siren outside. With the decline in tobacco use, energy balance will become the leading cause of cancer death in the United States within the next 5 to 10 years. Next, please. Here we have obesity rates in the United States versus a number of other countries. This is a true American problem. It is increasing as a problem. It will be a greater problem in the next decade. 15% of Americans were obese in 1970. It's 35% today. You can see the number 2 country on this slide is England. England has about 20% obesity rates, while we're at 35%. And note Switzerland, France, Canada. Next, please. There are some racial and ethnic divisions here. 60% of non-Hispanic Black women in the United States today are obese, whereas it's about 35% of non-Hispanic white women. Again, this is a problem that is increasing over time, and it's something that we need to address. Indeed, this is where health habits and culture actually come to influence cancer. And here we're talking about issues such as not having fresh fruits and vegetables available in inner cities, the fact that calories are cheap in the United States, high carbohydrate diets, by the way, in childhood in poor Black women have been linked to the higher prevalence of triple negative breast cancer in Black women in their 40s, 50s, and 60s. So long-term effects of diet are very, very important. Next, now let's talk about breast cancer. In 2019, these are the numbers diagnosed and dying in the United States. It's important to note that while there's been a 29% overall decline in death rates from cancer, from all cancers, from 1991 to 2017, from 1990 to 2016, there was a 40% decline in death rate from breast cancer. What this means is, in 2016, the risk of the average 55-year-old woman dying from breast cancer ever in her life was 60% what it was the risk for the average 55-year-old in 1990. And again, 40 to 50% of this is attributed to screening. The rest is attributed to improvements in treatment. Next, please. Here you have that decline by race and ethnicity. I showed you this before on a slide that had a number of other diseases. You can see blacks in red, whites in blue. The black-white disparity only existed after about 1980, and the other three races and ethnicities have a lower death rate than do whites. Next, please. I should note that while that's the United States as a whole, there's 7 states in the United States where there is no black-white mortality disparity. There literally are 7 states that have shown us that you don't have to have a black-white disparity. If the disparity is due to biology, one has to argue that blacks in Massachusetts and Minnesota have a biology that's distinctly different from blacks in other states. Next, please. Go ahead. Yes, thank you. It's important to note as we talk about health disparities that it's actually been documented that 40% of all women in the United States, be they black, white, or other, get less than optimal care for their breast cancer. There's something wrong with the quality of the surgery, the quality or dosing of chemotherapy, the aiming of radiation, or the receipt of surgery, radiation, or chemotherapy. Keep in mind, one of the most cited of my papers shows that 7% of black women in metropolitan Atlanta in 2000-2001 who were diagnosed with an early stage breast cancer got no treatment beyond the diagnosis. They got no surgery for that for 2 years after the diagnosis. So what this is Jeannie Mandelblatt and a group of people at Georgetown and the National Cancer Institute and a number of epidemiologists did some modeling studies and asked the question, what is the most effective way to reduce the death rate from cancer? There's a lot of wording here, but what it basically means is if we wanted to reduce risk of death most effectively, what we would fix is the fact that 40% of people get less than optimal treatment. If we kept screening rates as they currently are, at about 60% of women getting screened for breast cancer by somebody's guideline, by 2025, we would, by fixing treatment patterns, we would actually save more lives, 11,000 to 14,000 lives per year by 2025, maintaining screening as it currently is and fixing treatment issues. If we kept treatment at its same lousy rates and took screening rates up to 100%, we would actually save 5,000 to 6,000 lives. Keep in mind, if we fix the fact that 40% of people get less than optimal therapy, we would save twice as many lives by per year by 2025 than if we took screening rates up to 100%. You can see one of my pet peeves is the American public is obsessed with screening and never obsessed with getting everybody optimal care. Now, if you gave everybody optimal care and screened 100%, you would save 18,000 to 20,000 lives. Next, please. Colon cancer. The numbers as given to us by the American Cancer Society for 2019, about 51,000 deaths. Importantly, since 1980, the colorectal cancer screening rate, since 1980, the colorectal cancer death rate has halved. It is half what it was in 1980. The average man, the average woman in the United States today, their risk of dying from colorectal cancer is half what it was in 1980. Screening has caused about 2/3 of that decline. Next. This is for women that death decline. You can see the black-white difference in red and blue. And then the next slide is men. You can see the death rate decline again in red and blue over time. And then let's go to the next slide. This is an important point. This shows that insurance matters. Stage 1 is red, stage 2 is blue. The dotted lines are uninsured or Medicaid. The solid lines are insured. And what I don't like to show 5-year survival statistics because so frequently they are misinterpreted. Indeed, even most professionals that talk about survival statistics to a professional epidemiologist are misusing them. But I'm going to show you survival this one time. Please note that the chances of a stage 1 patient surviving 5 years is in the solid blue line. This is stage 1 uninsured. I'm sorry, I'm getting lost here. Stage 1 uninsured is the red dotted line. Stage 2 privately insured is the solid blue line. And the point here is you're more likely to be alive at 5 years with a more advanced stage 2 cancer with insurance than the less advanced stage 1 cancer without insurance. Now, please note, this was a slide that was prepared by epidemiologists at the American Cancer Society in an argument for the Affordable Care Act. You'll note the timing here. The uninsured and Medicaid line is here because no one in those days had Medicaid for prevention of cancer. They didn't have Medicaid such that they could go and get a screening test like a stool blood test for screening colonoscopy. These people got Medicaid a week after they were diagnosed with colon cancer after going to an emergency room with bleeding from the rectum or something like that. Next, please. Now, I've told you that there's been a halving of the death rate from colorectal cancer in the United States as a whole. This slide actually shows you the decline in death rate by state from 1980 to 82 up to about 2015. The dark blue states in the Northeast have had 55 to 63% declines in risk of death from colorectal cancer. The purple states, 12 to 31%. And one might ask, what is it about Massachusetts that can have a 63% decline in risk of death from colorectal cancer versus Mississippi that only had a 12% decline? Literally, everybody started out the same in 1970 to 1980, and we've had a dramatic decline in one state, but not another. And you can see huge variability around the states. And the new health disparity is Massachusetts versus Mississippi, not black-white. By the way, whites in the southern states did poorly compared to whites in the northeastern states. Next, please. One example of one of the problems that we see, and this is actually a wonderful study Kim Rhodes at Stanford did just a few years ago. We see variations in the quality of how pathology samples are being handled. And she actually noticed that Hispanics and Blacks in California had less lymph nodes dissected out by the pathologist compared to whites. And she, being a surgeon, knew that most pathologists are not racist. Why is this? She eventually realized it was hospitals that Blacks and Hispanics or poor people go to are overwhelmed, and the pathologist will typically have 5 or 6 samples from surgery to deal with per day, whereas hospitals where middle class and insured people tend to go, the pathologist only has 1 or 2 cases to deal with in a day. And so this is a structural socioeconomic thing that's actually causing the racism. By the way, the fact that Blacks who are stage 2 because they are 0 out of 6 lymph nodes positive are very likely to relapse versus whites who are stage 3 because they are 1 out of 25 or 30 lymph nodes positive at surgery, is part of the reason why we have this false belief that colorectal cancer is more aggressive in blacks versus whites. So this is a social construct that leads to us having racist views about the biology of cancer. Next, please. So we really need to talk about disparities and differences in screening, treatment, even processing people's pathology, and their differences by race, socioeconomic status, and region of residence. Now let's talk about breast cancer. Next slide, please. I'm sorry, lung cancer. These are the numbers for lung cancer in the United States, 154,000 deaths, most common cause of cancer death for both men and women in the United States. Let's look at the next slide. This is lung cancer mortality in the United States in the early 2010 to 2015 period. The darkest states, you'll remember when we looked at smoking, many of those dark red states were the states that had the highest smoking even to this day. And if you looked at smoking 30, 40 years ago, the dark red states had the worst smoking and the lighter states had the least as well. Next, please. By the way, if you look at states taxing of tobacco, the states that were dark red have the lowest tax of tobacco and the greatest use. When we talk about disparities overall, this is not lung cancer, this is an overall statistic. Please look at risk of death from cancer in Utah versus risk of death from cancer in Kentucky. People who live in Kentucky have almost a third greater risk of dying from cancer than people who live in Utah. This is, of course, heavily influenced by lung cancer deaths in Kentucky. Next, please. And smoking in Kentucky. Now, we talked about lung cancer screening. This is a great example of how we need to be very, very careful because people in the United States tend to stress the positives and not the negatives for lung cancer screening. This is the National Lung Cancer Screening Study, the best screening study in any disease ever done. It was done in 30 of the best hospitals in the United States, involved 54,000 people who were smokers who volunteered for screening. Next, please. It showed that there was a 20% relative risk decrease in death in people who got spiral CT compared to people who got a sham chest X-ray. And it is the basis for which we are excited about the fact that spiral CT screening in people at high risk for lung cancer because of an extensive smoking history saves lives. The important thing, though, is the 20% relative risk decrease, which is actually a little higher than that now, is actually 5.4 lives saved for every 2 people who went to an intensive care unit because of an invasive procedure, and every 1 life lost due to an invasive procedure. When we look at the screening test, it actually shows us very well the benefits and the harms. 5.4 lives saved for every 1 life lost. By the way, of the people who died, about 1/3 of them did not have lung cancer on autopsy. They got a biopsy because the screen had a false positive. Keep in mind, the study was done in 30 of the finest hospitals in the United States. And those of us who practice screening epidemiology worry, what is that 5.4 to 1 ratio when it moves to the general population of the United States? And we start talking about screening being done in community hospitals versus screening being done at a Johns Hopkins or Memorial Sloan Kettering or an MD Anderson. Next, please. Indeed, we have estimates from models that of the current 160,000 who die from lung cancer every year, if we went to screening all people who were eligible for lung cancer screening, we would prevent between 8,000 and 10,000 deaths per year when we got the steady state, and at a cost of 1,500 to 1,850 deaths caused by screening interventions. Next, please. This has led many of the more respected organizations to recommend informed decision-making before advocating lung cancer screening, as opposed to simply telling people, we recommend that you get it. Tell people it exists, it has some good and bad, you need to understand that, and then you as an individual need to make a decision as to what is right for you. Next, please. How can we provide adequate, high-quality care, I think has been a theme of this entire talk. And we also need to realize that unnecessary care interferes with institutional abilities to provide necessary care. That is to say, unnecessary screening, unnecessary diagnostic interventions actually prevents us from providing care which can actually save lives. And state-by-state disparities are increasing with the Affordable Care Act, unfortunately. Next, please. This is a slide that tells us the states that have expanded the Affordable Care Act in blue and the states that have not in orange. You'll notice that many of the orange states on this slide were the purple states in my previous slides. We're going to see more disparities by state as people in the blue states have Medicaid and the ability to seek care early when they have symptoms, and the ability to actually get involved in some of the good, productive screening interventions that actually can save lives. I'm even more excited about the potential of being involved in the healthcare system where they can be counseled about good health behaviors regarding weight gain and exercise, not smoking, and so forth. Next, please. Ending the true cost of healthcare to me as a cancer doc. This is data that was done just as I was leaving the American Cancer Society, my swan song as Chief Medical Officer of the American Cancer Society. We know that college-educated people have a much lower risk of dying from cancer. And we know that college-educated people are not biologically different from non-college educated. They may have some different health habits and some different interactions with the healthcare system. Next, please. The ACS regularly estimates how many people are going to die every year from cancer. The estimate's about 600,000 in any given year. We just wanted to know if all Americans had the risk of death of college-educated Americans, how many would die? And the answer is 22% would not die. About 132,000 of the 600,000 lives that are lost every year would go away if all Americans had what college-educated Americans have. That is access to good risk reduction and prevention activities, access to good screening, access to and use of good care. Next, please. This 132,000 Americans, the majority of them, by the way, are white Americans. They overwhelmingly live in the southern United States, although they live in every state. They are predominantly white and predominantly living in the South. You see, the issue of health disparities for this country is not going to be a racial issue. It's going to be really a human race issue. I would note, next please, that 132,000 deaths that would be prevented. You can go to the next slide. That 132,000 deaths that would be prevented, that's more powerful than any drug that we have. There's no breakthrough treatment, no breakthrough drug, no breakthrough screening that is as powerful as simply getting to all human beings the technologies, risk reduction, screening, prevention, diagnosis, and treatment that we already have. Keep in mind, some of these risk reduction technologies involve preventing teenagers from smoking, therefore they won't die when they're in their 50s and 60s. Again, this is the 29% decline that we've had over the last 26 years. Next, please. What we modeled is where would that decline be in 2035? If we continue on the path that we currently are, we believe by 2035, we're going to have a 26% decline from 2015. If we did everything we possibly could do to help all Americans, get them the care that they need, we could have a 38% decline from 2015. Essentially, what I'm saying is that we are literally at a point in time where our options are we can have a 50% decline from about a 50% decline from 1991 in 2035, or we can have close to a 65% decline in cancer death rates from 1991 to 2035. If we were to do what we should do as a society, by 2035, we would actually get the cancer death rate back down very close to the cancer death rates that we had about 1900 in the United States. And so that is really the bottom line of this talk, trying to get everyone adequate care, be it preventative or risk reduction or therapeutic. If we could try to do that to everyone, it's much more powerful than any research has ever given us in terms of a therapy or a preventative. Thank you. Next, please. The control of cancer is through disease prevention or risk reduction. It's through getting people appropriate screening and treatment, and it doesn't involve any new breakthrough drug. The breakthrough is getting everybody what everybody should get. Next. So how can we provide adequate, high quality care is, I think, incredibly important. Next. It's important to note that the greatest scientific progress has actually been through prevention. And every time we have an improvement in treatment, we actually increase disparities in populations. We saw that with breast and colorectal cancer, black versus white. What happened around 1980? We learned how to screen and treat for breast and colorectal cancer. We're going to see it in the era of precision medicine and immunotherapy, and prevention is less likely to cause these disparities. Next, please. I should say risk reduction. And so it's all about giving populations what they need to get where we all want to go. It's not equality. Certain populations, especially in the southern United States, are going to need a little bit more than populations, for example, in the Northeast. Next, please. This is my last slide. This is the old Johns Hopkins Hospital. A little bit of medical history. This is where Sir William Osler, one of the inventors of internal medicine, used to practice in the 1890s. And today, doctors round in the morning because the patient rooms were under that dome. And every morning, Dr. Osler used to walk around and see the patients. And this is also where Dr. Osler's young student doctors used to live. They lived up in the dome. They were residents of the dome. And this is the building where medical residencies first started. And so I'll stop at that point if you have any questions. Again, thank you for inviting me to this new and very interesting technology.
Dr. Brawley, thank you so much for that fantastic overview of the cancer mortality rates. I'm Lindsay House. I am the Senior Policy Manager at NCCS. And I had a question for you, and I also wanted to talk a little bit about the current crisis that we're facing right now, and that I think is on a lot of our minds with the coronavirus and how that might impact cancer patients. We, as you can see the slide here, we have partnered with ASCO and a few other organizations to address some of the concerns that cancer patients are bringing to us as they, consider how they might be impacted by the COVID-19 pandemic. And so if you go to canceradvocacy.org at COVID resources, there's some really important information there that we've worked with some amazing experts. And if you have any additional questions, we would love to. This is a live document that we're adding to daily, so please reach out to us if you have any additional questions. And so, as you mentioned, Dr. Brawley, that access is such an important piece in getting to equity in healthcare, especially in cancer care. And I just wanted to know what your thoughts were on the trauma that the coronavirus might have on our healthcare system and how that could, potentially push us to reconsider our entire system and how that reconsideration could impact cancer care in general. And I know that's a really big question, but I think it's on a lot of our minds right now. I'd love to hear your thoughts.
Yeah, we have put a lot of cancer care on hold. I'm hoping it's a temporary hold until we can get through this disaster that is the COVID-19 pandemic. At Hopkins, we're not starting much of our adjuvant therapy. We are in many diseases actually delaying initial surgery and initial treatment because the hospital is so overwhelmed right now in taking care of people who, if they weren't taken care of, are going to die within the next several weeks or months. And so that's one issue, is we have people who have active cancer, have diagnosed tumors, and are being asked to wait and not get treatment. The next issue is patients who we are treating because treating their disease is an emergency. We are putting them into an immunosuppressed state where they are more likely to contract the COVID-19 virus than someone who is not immunosuppressed. And those people we definitely have to keep isolated and keep away from the general public. For them, social distancing and isolation, quarantining is actually imperative because they are at very, very high risk for contracting the virus, and they don't have the immune system that allows a goodly number of people who are infected with the virus to overcome the infection.
And so related to that, we were actually just yesterday reading an article by Dr. Schulman and his colleagues on the oncology workforce shortage. And in light of the coronavirus outbreak, and we've heard so much in the media about shortages in general, but specifically in oncology and how that's been an issue even before this crisis. And so can you speak a little bit about how that might change now?
Well, long term, we have a shortage of medical oncologists. We may be able to overcome some of that through use of physician's assistants and nurse practitioners. But people who take care of cancer patients, and without the COVID-19, 2025, 2030, there's going to be a shortage of people to take care of cancer patients, and this is going to interfere with the quality of care for sure. In the short term, we at Hopkins have taken a good deal of our workforce in oncology to take care of people who are more acutely sick with other diseases, some with COVID-19 and some sick with the usual stuff, so that the docs who would normally take care of them can go take care of folks who have the coronavirus infection. So this is a huge problem. Both there's an emergent problem, and then there's a long-term problem that we're going to have to overcome. There's not been an investment in medical infrastructure in general. We're finding that out now as we talk about the shortages of protective equipment and shortages of intensive care unit beds and ventilators. You know, in terms of intensive care units and ventilators, our ratios to the population are much worse than they are in Italy or Spain. I mean, they literally have more intensive care beds per 1,000 people than, or per 10,000 people than we do in the United States. We're not planning for workforce, just as we're not planning for equipment in healthcare.
Right. Thank you, Dr. Brawley. And we have one final question for you. And for those of you, I know we have a couple questions in the chat box. We will try to follow up with you as soon as possible once the roundtable is concluded. But I have one question related to the resource that I was talking about earlier, and the fact that we've, you know, and I know many other organizations out there probably are experiencing the same thing. We've been contacted and speaking with so many cancer survivors who, you know, are really feel uniquely vulnerable right now with their immune compromised state. And so I'm just wondering, you know, what would you say to those survivors who are feeling anxious and fearful about what we're going through right now with the coronavirus?
The most important thing you can say is we understand the concern and we share that concern. Then encourage them to stay isolated and practice all of the things that everyone else should be practicing as well. Good hand washing, trying to avoid contact with other people. Good hand washing is the absolute most important thing. I see a lot of people wearing masks now. I would be careful wearing masks. You do see folks wearing masks in China, for example. The Chinese government mandates that because the mask prevents the infected person from infecting other people more than the mask protects the individual who is wearing it. Now, I'm talking about your typical surgical mask. When we're seeing patients who we think are infected, we wear the N95 respirator, which protects us from breathing in the particles. The reason why I'm concerned about people wearing these surgical masks, thinking it gives them protection, is what it ends up doing is causing them to manipulate it, and that means they're touching their face, touching the area of their eyes, mouth, and nose, and it actually may increase their risk of contracting the virus rather than protecting it. Remember, these surgical masks more protect an infected person from infecting other people. The way to think of it is, when we go to the OR, we wear a surgical mask not because the doctors and nurses in the OR are concerned about catching something from the patient. We wear it to keep from giving the patient something from us.
Right. Great. Those are great. That's great advice. Thank you so much. And I just want to say thank you again, Dr. Brawley, for taking time, especially during this very busy time, unprecedented time. And I want to let everybody know that we're going to be trying to move along with the schedule. We'll take a very brief break right now, but we'll get started with the next panel at 10:30. And I know we're all virtually clapping for you right now, Dr. Brawley. We really, really appreciate you and all your valuable, insightful information.
Well, I just want to say thank you. You know, NCCS, going back to Ellen Stovall 30 years ago, have been so supportive of me and so supportive of our efforts. It's just a privilege to talk to you, and thank you for all that you do.
Thank you so much, Dr. Brawley. We're so grateful to have you with us today.
Hi, I just want to, hi, I'm Shelley Foldnasso, CEO of NCCS, and while we're getting ready to start the next panel, I just wanted to make one quick point. about the value of advocacy, because in our last session we heard from Dr. Brawley, and he a couple of times said risk reduction instead of prevention. And I want to give a shout out to our advocates as part of our Cancer Policy and Advocacy Team program. When Dr. Brawley came last summer and presented to our CPAT symposium, and he talked about prevention. And after his presentation, a group of advocates basically accosted him and said, like, had engaged him in a conversation about why, as advocates, they felt like that prevention was not the right word we should be using, because we can't actually prevent cancer, we can only reduce the risk. And Dr. Brawley talked to them and engaged in a really serious discussion about it, and you can see that it's affected his, the way he talks about it. So I think that's a win for advocacy and for the advocates who really want to share the patient perspective, because they felt like, by calling it prevention, when we don't actually prevent cancer, we just reduce risk, it almost they feel like there's almost a burden or a stigma on patients who then are diagnosed with cancer, that they didn't do what they were supposed to do to prevent it, when it's actually just reducing risk. So that is just why advocates are so incredibly important, to be involved and to have these kinds of conversations with clinicians and researchers to share patient perspective. And you can see that Dr. Brawley took it to heart, and we really appreciate him for listening, and all of you advocates who share that perspective. And we're grateful that you're all on, that so many of you are able to be on today.